I am Nicole Fox. Nice to meet you all. Um, Lots of folks on this call that I have met and lots of folks I haven't met. So thank you for sharing time and space with me today. I am going to attempt to share my screen. Hopefully it'll go pretty well. I am the kind of speaker who likes interaction. It doesn't throw me off if you ask questions, as long as you're not a heckler. But I do understand that because there have been some strange heckling events that's not as easy to do in the platform today. So if you do have questions, throw them in the chat and the facilitators will try to help interrupt as needed, or we can kind of put them at the end with the Q&A. I was told I have 25 minutes. I'm counting my time, not from 12, but from now. And having said that, might need a little reminder because I do have the gift of the gab. So let me find my screen, make sure I'm going to share it properly with you. Let's see if I can get it to, can you see that? Awesome. Okay. So we're going to talk about borderline personality disorder today. It's one of my favorite things to talk about. I usually contextualize this as in comparison to bipolar disorder, not because I think they're so wildly alike, but since I've been practicing in Idaho, I have noticed that lots of folks get diagnosed with bipolar disorder who actually have borderline personality disorder. Not that you can't have both. But sometimes the presentation, like so many things in psychiatry, can be confusing and there are overlapping symptoms. So I'll do a lot of comparison here. I don't have any disclosures. We'll go through a case. We'll talk about the criteria. I'll try to make that less boring. We'll talk about treatment, and then I have a little bit of a book resource list at the end. So I can see this thing about me sharing on my screen, but you can't see that, can you? You can only see my slides, right? Right, great. Okay. So my clinical practice is in consults, and so I see patients in the hospital. And so this is a case that I received a call on. Hey, we have this bipolar patient. She's on hold for suicidal ideation and she is psychotic. So I ask, what is she doing that's psychotic? Well, she's agitated in the emergency department. She's yelling and shoving, just totally disorganized and manic. She had to get Zyprexa IM, olanzapine, to calm down. Now she's having terrible visual hallucinations and voices to kill herself. So I ask, are there any notable medications or labs? No, there's nothing. I'm going to see if I can actually move this bar. I can. So the chief complaint and identifying information is that this is Tamber. She's a 32-year-old bipolar patient admitted with mania and SI. So a little bit of history. Make sure I didn't. Okay. A little bit of history here. Tamber has plans to overdose on all of her pills. She has many of them. Roommate has been pressuring her for oxycodone and clonazepam. She feels unsafe at home and has suicidal thoughts and says, if I have to go home, I'll kill myself. She's been having auditory hallucinations of mean voices. A mean voice, one in particular, has been present on and off since about age 9. She can't get good sleep as her mind is just going nonstop. She's restless and irritable, and she says, I am super moody when I'm manic. She's been cutting for stress relief since her teenage years. She had some significant abuse in childhood, including sexual abuse. Her biological mother died from an intentional overdose, and she was raised in foster care. So some notable descriptions from Tamber include the following. I was getting so paranoid at the house. Everyone's talking about me. I rapid cycle from high to low every day, day to day, and sometimes even hour to hour. So I know there are a few psychiatrists in the room. We can talk about what rapid cycling really means and the true definition of that. And maybe I'll just do that right now. Rapid cycling, many patients and sometimes healthcare practitioners think that rapid cycling means they cycle. It sounds different than it is. It sounds like, oh, I'm going to rapid cycle up, down, up, down, up, down. No, that's moody. Rapid cycling actually means that you have had 4 distinct mood episodes in the course of 1 year. And each of those mood episodes needs to meet criteria for a true mood episode. A mood episode um, may be an episode of depression that lasts, 2 weeks or more, or it could be an episode of mania that lasted a week. But it's 4 mood episodes in 1 year. So just keep that in mind when your patients say, I'm rapid cycling, I'm just up and down all day long. She also experiences memory loss around the times of mania. So she describes this as my roommate stresses me out. And apparently, I'll say things I don't even remember. Once I ended up at the store and I don't even remember driving there. Now, it is true. Patients who are manic and end up in the psychiatric hospital will often not remember their episode of mania. That is a true statement. But losing moments of time during your day is not necessarily consistent with what we would see in mania. That's consistent with a different phenomenon that we'll talk about. I never felt great when I asked, how did you feel? How do you feel, Tamber? Have you ever felt good? I never felt great. I wish, kind of as if. Sometimes I'm so impulsive that I spend all my money. It's worse when I'm depressed. Now, we talk about impulsivity and overspending and mania so often. In mania, we think about patients have just rushed out and bought a new boat, or they've spent down all their savings. And we think when we hear that kind of story, oh my gosh, I have to really be worried about mania here. But the question for me becomes, why was the person impulsive? What led to that act? Was a patient grandiose and felt like they have all the funds in the world and no cares in the world? Or did that person feel deeply empty inside and they needed to fill that hole with consumer goods or food or sex or other things that momentarily might lead to feeling good, but then lead to significant feelings of shame? That type of filling the empty hole with substances or with things is more consistent with a personality disorder. So Tamber says, I cannot sleep. I'm so tired. Can you just give me something for that? This happens when I'm manic. So again, here, I, and I title this case, The Devil's in the Details. We've got a patient who, and in an environment where we had an hour to go through this, I would, let you pepper me with like, what do you think this means? And what do you think that means? But we just don't have that in this kind of short abbreviated time. So you know what? A manic patient, when you say, how much are you sleeping okay? If you just say, are you sleeping okay? And they're like, yeah, I sleep, I'm fine. And I wake up and I feel great. And you say, oh, okay, how much are you sleeping a night? Oh, I feel great after 2 hours of sleep. Maybe after weeks and weeks of that, they're going to say, yeah, I'm starting to feel tired, but I'm awake, I'm awake, I'm awake. Usually you don't see, I'm tired, I have insomnia, give me something for that in bipolar disorder, but you might see that in any number of other psychiatric disorders that people don't sleep well, in which people don't sleep well. So the patient, Tamber, has had numerous prior inpatient psychiatric hospitalizations. She sees a psychiatric NP in the community. Therapist is moving offices from Nampa to Boise. This is big. So we don't often think about this, but our patients, especially those with personality disorders, are very sensitive to change and what we would call psychosocial stressors. So mania isn't particularly responsive or caused by psychosocial stressors. But when we have an exacerbation of a personality disorder, it's often triggered by a social stressor. And there is nothing more stressful to someone than the thought of losing their beloved therapist or their beloved NP or beloved doctor. Um, so uh, Tambers had diagnoses of bipolar disorder, schizoaffective disorder, depression, anxiety, and borderline personality traits. Has had several overdose attempts, also tried to strangle herself at one point, has a history of cutting, has tried many medications without relief of auditory or visual hallucinations. This is another thing I'd like to just mention briefly with hallucinations. Auditory hallucinations are what we really associate with psychotic disorders and with mood disorders with psychotic features. It is vanishingly rare to have a visual hallucination um, of a psychotic etiology or primary psychotic etiology or a mood disorder or psychosis. When we see visual hallucinations, we typically think it's medical unless proven otherwise. By medical, I mean a dementia picture, a mass effect of a lesion in the brain, intoxication, detoxification. Um, I don't know if I mentioned dementia picture. So when we see especially a well-formed visual hallucination, we often think it's not psychiatric. Having said that, in the personality disorders, we will more typically see someone who has um, a different type of visual hallucination, what I will call and what is officially called an illusion, as opposed to a hallucination or an illusion is when someone does actually see something, but their brain misunderstands what it is. So out of the corner of the eye, you could see a leaf rattle on the ground, but maybe your brain thinks it's a mouse. In the same way, you might hear your name whispered in the wind. And those types of phenomenon are much more common in people with personality disorders. This is her medication list. She's taking aripiprazole, benztropine, carbamazepine, prazosin, pregabalin, quetiapine, trazodone. I'm not sure why she's taking benztropine. That is a medication we would typically associate with the need for a really potent antidopaminergic agent like Haldol or Risperdal. Um, so lots of medications, and this is sometimes a clue when a patient's requiring a lot of different medications and we're still not getting resolution of symptoms, that maybe the diagnosis is, we haven't honed in on the right diagnosis. So I just highlighted some things that stood out about her mental status exam. She had pink hair. She Her mood was stated as depressed. Her affect was labile, meaning that she was kind of all over the place. Sometimes looking depressed, other times, laughing, um, tearful, angry, childlike, sort of all over. Thought processes. There was no sign of formal thought disorder. She had that single internal critical voice, and then she reported seeing demons and devils flying across the room at times. So here's our diagnostic confusion, the element of confusion here. So is this patient really having bipolar disorder with mania, or is she actually suffering from borderline personality disorder? And I think I have tried to bring you along that this is probably not bipolar mania from which she's suffering. This first video, and in a minute, I'm going to turn over control to Shannon so she can play this for you. This first video is a quick clip um, of a psychiatrist describing borderline personality disorder. And then the second clip is a person with borderline personality disorder's internal monologue. So I'm going to stop sharing now, Shannon.
People with borderline personality disorder, they often describe their feelings as feeling empty. They will describe being left alone, people not liking them, not being loved. this sense of profound emptiness, this sense of being abandoned. It's a very painful disorder to have. And the reality is not often true because the perception is always that of a negative realm. Some of the signs of the borderline personality disorder, and oftentimes people around you will actually identify this aspect of your being. Examples such as a person that has a history of very impulsive, highly emotional relationships where there was an amount of abuse that either the individual himself abused somebody or that another person abused them. Sense of abandonment, always feeling that they're going to be left alone, and as a result of that there's this clinging nature. And also sometimes the person with the borderline personality, because there's such this profound sense of emptiness, they will also do self-harm behavior. And some of the more common examples of self-harm behavior would be the example of cutting their arms. And oftentimes when you speak to a person suffering from borderline personality disorder, you ask them, what do you get from cutting or from burning? They will say that what I get is a sense of being alive, a sense of feeling something, a sense of being taken away from the pain that I am suffering from.
I wake up with the sense of dread. How is today gonna go? How are my moods gonna be? How are the people in my life going to act towards me? How am I gonna perceive people? Are they just being nice to me because they want something? Are they being condescending? Are they just pretending to care like everyone else? No one really loves me. How could they? I don't even love myself. They tolerate me because I'm nice to them and because I help them if needed. They can ask me to do anything and I will do it. I just want them to like me. I want everyone to like me. I mean, why would anyone be mean to me? I go above and beyond for everyone. People are so ungrateful. Wait, I haven't heard back from them yet. They didn't answer my text. They're avoiding me. They hate me. I've ruined a good relationship again. I'm such a terrible person. I can't handle them being mad at me. I'm so stupid. Why can't I just be normal and get along with everyone? Oh, never mind. They texted me back. I'm just gonna text them about something funny and unrelated and see if they respond. This is just a glimpse at what goes through my head in a regular day. My life is a series of never-ending questions, judgments, and reactions. It has nothing to do with anyone else, and yet, at the same time, everything to do with them. If borderline is a part of your story, know that your feelings are valid and that the way you experience the world is real. You are not alone.
Okay, I guess it put me back at the beginning. So, as you can see, it's a really painful disorder. People who have, and because I turned my phone off because of the emergency alert, how much time do I have?
You've got about 10 more minutes.
Oh, perfect. It's a really painful condition for people to have. We often in the healthcare field often find folks with borderline personality disorder upsetting or frustrating or even annoying or manipulative. And the truth of the matter is, if someone has borderline personality disorder, they're living a very painful existence. Their relationships are tumultuous. They are feeling all the feelings so deeply, like every little thing in life is a sucker punch. Um, it's a very hard condition to coexist with. Um, so this is just if you Google bipolar disorder, actually, you'll get a lot that comes up that seems to feature more borderline personality disorder features. And I thought this borderline personality disorder bingo was pretty interesting. This these things exactly describe borderline personality disorder. The person has self-loathing. Um, they are seen as manipulative. They ruin relationships. They split. What do we mean by split? It means that we overvalue and undervalue. So maybe they see me and it feels really good for my ego to to hear the patient say, "You are the first psychiatrist to ever understand me. You listen, you really get me. That other psychiatrist, he didn't even listen to me. He didn't get me, and he certainly didn't know me and how I react to medicines the way I know me." So they overvalue me and they undervalue you, or vice versa, and that can switch on a dime. And those feelings are really real and intense to that person. They believe these things. Um, they just have a really unstable identity and this kind of chronic feeling of emptiness typically. And not every single person with borderline personality disorder has the exact same symptoms. And some people are um, quite well compensated and manage their borderline, and other people, the ones that rise to the degree of illness that they end up with us, are the ones who are much more decompensated typically. So, what is a personality disorder? It's an enduring pattern of inner experience and behavior that manifests with two or more of the following: um, cognition, affectivity, interpersonal functioning, or impulse control. So, meaning they may have a different way of perceiving and interpreting themselves and others. Their affective range could be intense and labile. They may have difficulties with interpersonal functions, um, meaning that, like the girl in the video, the woman in the video, she texted a friend and they didn't respond immediately. And so she automatically thought that there was a problem in that person hated her. So she perceived that there was a big problem, and that had she texted something nasty back, that would have impacted the interpersonal functioning and also spoken to a level of impulse control. This enduring pattern is inflexible and it is pervasive. Sometimes in psychiatry, we talk about state versus trait. So a state, like a mood episode, is a state at a moment or a few weeks at a time, whereas a trait is a pervasive part of this person um, across a range of settings. This can lead to significant distress or impairment, and the pattern is stable and can be usually traced back to adolescence and early adulthood. The specific criteria for borderline personality disorder, and there are lots of ranges thrown out there as to what percentage of the population suffers from borderline personality disorder. 2 to 3%, according to one study, up to 6% in other studies. The specific criteria for borderline is that enduring pervasive pattern, so a personality disorder, of instability, of interpersonal relationships, self-image, and affect, and marked impulsivity as indicated by 5 or more of the following. And, it never works out well to just ask the patient, like, do you have this criteria? Do you have that criteria? Do you have this criteria? But once you have made your assessment, it is very helpful with some patients once you've built rapport, because, rapport is really everything. If they never come back to see you, they can't get better. Um, so if you think they meet criteria, it's sometimes helpful to open up the DSM and say, gosh, I'm just wondering if this sounds like any of this feels like right to you. Like, does this sound like you? And sometimes folks with borderline personality disorder will feel really seen if you are able to have that dialogue with them. So frantic efforts to avoid real or imagined abandonment, that's what we saw in our case. Unstable and intense interpersonal relationships, also in our case. Identity disturbance with an unstable sense of self, meaning there's just really not a sense of self. The sense of self is either kind of it's a vacuous, empty feeling, or it's ever changing. Identity, I just said that, impulsivity in at least 2 areas that are potentially self-damaging. And this is just, it is a pervasive pattern. It's not with a specific mood episode only. And by mood episode, I mean depressive episode or manic episode. Recurrent suicidal behaviors, gestures, or threats, or self-mutilating behaviors, affective instability, chronic feelings of emptiness, inappropriate intense anger, and transient stress-related paranoia or dissociative symptoms. And so that is what we saw in the patient in the case in Tamber. She was so stressed by her conditions that she looked paranoid, and the hospital team thought she was paranoid, and she was paranoid. Um, and it can rise to the level of looking psychotic, but that doesn't mean that it was a mania with psychosis. So we need 5 of these guys. And then a distinctive, so we're not going to really talk about bipolar disorder here because I don't think we have enough time, but this is here for you to compare it. If you want kind of to further dive into where there's overlap, specifically with the sleep, the impulsivity, and kind of risk-taking behaviors. So what do we do for borderline personality disorders? The primary treatment for borderline personality disorder is therapy, CBT, DBT, mentalization-based therapy. And you can augment with an SSRI or a low-dose second-generation antipsychotic or mood stabilizer. So in CBT, they're gonna the CBT therapists, and there are many therapists in the room today who can probably speak to this better than me. But CBTs, we're gonna focus on the patient's thoughts and how thoughts can change their feelings and behaviors. We're gonna focus on kind of automatic thoughts. So when I say to you, for example, you hear a knock at the window, what is your automatic thought? Normally you'd be able to respond to me. So if you hear a knock at your window at night in a rainstorm, let's say, what's your automatic thought? When I ask people this question, most people automatically assume it's someone trying to like break in. So an alternative explanation for that might actually be that it's Romeo throwing a rock at your window. So we can help patients to recognize automatic thoughts and to look at alternative explanations to what's going on, so that they can start to pause between their stimulus and response, as the great psychiatrist Viktor Frankl would have recommended. So DBT, that is a form of CBT, actually. And so this would suggest that those with borderline personality disorder feel intensely, we know that, and are emotionally aroused quickly. And they just take longer to get back to their baseline. We, with DBT, focus on mindfulness, paying attention to the present emotional state. We teach skills to help control intense emotions. For example, ice holding exercises when someone feels they're ramping up, taking a cold shower, splashing water on one's face. Um, some people like the rubber band. I don't like the rubber band because I think you could really actually hurt yourself if you do it enough. Um, and then this DBT often will pair individual and group therapy. And it was initially, DBT was initially created by Marsha Linehan for people with borderline personality disorder, and as a person who has self-identified as having borderline personality disorder. Now we know that DBT is used for a number of different conditions. And then mentalization-based therapy, that really helps patients learn to identify and understand what others may be thinking or feeling. There's some school of thought that those with borderline personality disorder may not be able to put themselves in other people's shoes in their lives. And this leads to these tumultuous relationships. And mentalization therapy really helps one put themselves in someone else's shoes. these are some resources that a colleague of mine put together. Some book recommendations. There's also Walking on Eggshells. If you just Google self-help borderline personality disorder, you're going to come back with more books than you could read like in the next 5 years. Here are some more. So I love this DBT training manual, and then there's an accompanying workbook that goes with it. Nonviolent Communication is a great book. So there's some books for you. I think that might be all I have. We have time and space for questions, but before we go to that, I want to tell you one thing, which is not completely self-promotion because Echo Idaho is co-sponsoring this event. So the Idaho Psychiatric Association's annual conference is on Friday, October 27th at the Galaxy Event Center, which is just over Wahoo's. And we this year decided that we really wanted to have this conference be accessible to everyone. So it's free for IPA members and only $50 for non-IPA members if you want CME credit. If you don't and you just want to go as general public, it's only $25. And we have, the topic is social psychiatry. And it's going to be a really neat talk. And there's a bowling party included at the end for everyone and lots of food. So come join us. It should be fun. See some familiar faces and make some new friends.
Thank you, Dr. Fox. That was
Yeah.
a great talk. You can go ahead and stop your share and we'll all come back together.
Okay.
We've got just a few minutes for some questions. But I did want to kick it off by saying that there was some talk in the chat about self-harm and self-mutilating with tattoos and BPD patients, and curious if you have any thoughts on that.
Oh gosh, I guess I would ask you, do they say they're self-harming with the tattoos, or is that your perception?
I think that's a good question to ask. Another question, do adolescents have BPD or can
Oh,
they?
so I'm still stuck on this tattoo thing. I was
Oh,
hoping
sorry.
someone would answer. No, that's okay because that wasn't meant to be. That was a curiosity, not a judgment, and or a demonstrated curiousness, I should say, because I want to approach these things with curiosity. And so I would say if someone tells you they are getting tattoos as a form of self-harm because they like the pain and it makes them feel alive somehow, I would say that's something to talk about in therapy and ask them, use some motivational interviewing at that moment and ask them, what do you get out of, what is it other than pain that you're getting out of this? And see if there are substitutions. Now, if it's your teenager and they just really want a tattoo, and then that's just a whole different story.
Dr. Reagan, let's go to you first, and then we'll come back to a question or two in the chat, and then we'll move on to our patient case.
Thanks very much, Dr. Fox. I'm a family doctor in Pocatello. Like a lot of people I know, at least, I hate the name borderline personality. And I find that I have a hard time explaining to patients what it means without feeling pejorative.
Mm-hmm.
I wish we had a different name for it.
Yeah, so the name for borderline personality is actually really interesting. Some of you may know where it comes from. So there was an observation that patients who are have this kind of personality structure live on the borderline between neurosis and psychosis. And when they're well compensated, they are just living more on the neurosis side. And when they're decompensated, they're more psychotic looking. But like so many things in this world, the names start out meaning something useful and become another way to stigmatize people. So I agree. I also don't like the name antipsychotic because I don't think it's particularly helpful. But sometimes we're just stuck with these things. I wish we could change them too.
I was actually gonna, this is actually what I was gonna ask you, Nicole. Thank you for your talk. I've heard
Yeah.
you speak about this a little bit in the past, and it's always super helpful. So I came across some literature, and I think it might be a little controversial because I asked another psychologist about it, and he was like, I hate that. But it was a writer, I think she's a psychologist who's written a couple books out of the UK, and she was referring to it as highly sensitive and emotionally intense or emotional intensity disorder. And I don't know. I mean, I actually kind of like that description. I think it gives it a little bit more possibility for a positive because I've found some of the patients and people in my life who have some of those traits, like they also have this amazing capacity for creativity and kind of there's this flip side of some of the positive sides of being a sensitive person and an intense person, and you can feel really good things too. And so her kind of paradigm is that she reframes some of that in a positive way. The psychologist I talked to felt like it kind of let people off the hook, that they weren't being kind of helped to support what they needed to maybe work on in their relationships, that they were kind of like, this is who I am and you have to deal with it. But
Mm.
I think it's an interesting paradigm, I guess.
So I guess what I would say to that is a couple of things. So, and thank you for sharing that. Certainly, there are highly sensitive people out there. I'm a sensitive person. I'm also an intense person, but I don't meet the criteria for borderline personality disorder.
Right.
And so I think there's a difference. I think people can be intense and people can be sensitive, but it doesn't mean that they don't have a sense of self or that
Mhm.
they live with this chronic feeling of emptiness or that
Mhm.
they lash out at the people in their lives and have tumultuous relationships. Um, so I would say that anyone with any of the features, all of us could probably benefit from therapy, right? And especially if we have any of the traits of a personality disorder, it could be very helpful to have therapy around those things. So someone could be a highly sensitive person and not meet the criteria. And then as far as letting someone off the hook, um, you know, I we're all on the hook for who we are, and at the same time, we come from a place of compassion where we're the aggregate of our life experiences and our neurological connections. So, um, yeah, so that's kind of an I think that there are sensitive people, and I think that there are people who are sensitive who meet criteria for borderline personality disorder, and
Yeah.
it's not a nice name. I agree because it's been stigmatized. There was a question in the chat that I did want to answer though. How do you balance giving empathy for their distress and then bringing more and more distress to the situation to get more empathy? Well, I guess what I would say is people need their cup filled up, and you're also not an empty like bucket of water to fill their cup, right? So we want to help people and have compassion for people, and folks with borderline personality disorder need more than many other patients. They often will stay more compensated. For example, if you're a family practice doctor and they're calling your front office like 10 times a day, um, and trying to get in for random reasons, if you could schedule a 15-minute check-in every other week or every month, I'm saying ideal world, I'm not saying you actually have time for it. That consistency and knowing they have a check-in time with you might be stabilizing for them. And so they won't be constantly pulling at you for getting their needs met because you'll have already established with them, hey, Joe, we're going to have a monthly check-in every Tuesday at 2, and that's our special time. I want to make sure you call in, and I want to check in with you. And then, unless you actually have a real emergency, I don't want you calling the front office. So I think you can always try to come from a place of compassion and kindness and give them what you can that they need and set some boundaries at the same time. What
Dr.
we see as manipulation is actually not necessarily them manipulating you purposely. they're really desperate to get their needs met, but their needs can never be met because there's an empty hole inside.
Dr. Fox, thank you so much. I think this is such a huge topic. I think our audience would be happy with 5 sessions on borderline personality disorder. So thank you so much for coming and putting it into a nice little knowledge burst for us. And we hope to have you back again in the future and continue these conversations. So thank you very much.